All right, my name's Lisa Diaz. I know a lot of you know me. I work weekends mainly. I've gone back to school to get my bachelor's degree because I want to be a nurse practitioner. So here I am, and I did hospice for about 10 years before I came here. And when I first came to work here last summer, a lot of people were really interested in learning more about hospice. I know the nurse I rode with, she was like, oh, when you talk to this patient about hospice, why don't you talk to this patient about hospice? I'm finally like, I'm not talking to any more of them. But so anyway, I'm going to give you just a brief overview of what hospice is, some of the myths about hospice, and when we're done, y'all can ask me questions if you like. I am by no means an expert, but I do know a lot. I was a manager and had to deal with the payer sources and all that too. So, you know, one thing I want to give y'all just a couple things to think about while we're talking. The Hippocratic Oath in modern terms says to cure when possible, relieve suffering always, and never prolong the dying process. So, you know, that's something we need to keep in mind with everyone. What is hospice? Hospice is basically taking care of people that have a terminal illness. You know, a lot of times people think that that means that I have to be dying within a week, and that's not the case. To be hospice appropriate, the doctor has to feel like you meet certain criteria that you could pass within 6 months. Now, there are people, of course, unfortunately, that come to hospice and die within a few hours because the families and the doctors have waited so long, or sometimes the person's not ready. You know, hospice isn't for everyone. It's very near and dear to my heart, and I want to go into palliative care. But, you know, it's not for everyone. Some people need to die having everything under the sun, you know, being done, on the table having CPR done. But it was started in the 70s because they found that, you know, so many people were dying in the hospital, and they weren't really dying well. So it kind of started off as a grassroots movement, and, you know, it was happening in Europe. So it really started with volunteers mainly. It wasn't even people being paid that started the hospice. And so they were trying to get people out of hospitals and back home. Now, home means wherever you live. You know, we see hospice patients that live in nursing homes, assisted livings, independent living, in their house, their neighbor's house, whoever. So that just means wherever they live. There's different levels of care. There's routine home care, which is when a person is at home, wherever that place is that they live. Then there's general inpatient care. You know, a lot of times people think, well, I'll just go to that hospice facility and stay there for 4 or 5 months. Well, unfortunately, that's not the way that it's set up. General inpatient units are set up to support the home team. You can't even have an independent hospice facility without having a home care team. If you're Medicare, Medicaid funded. So, you know, the general inpatient, if a person has symptoms that, you know, I started doing hospice a long time ago, back when we were delivering our own meds and everything, and we had very few hospice beds where I worked, so we did most everything at home. You know, most things truly can be done at home, but if somebody has pain that's just not getting under control, you know, nausea, vomiting that's not being controlled, they can go into the inpatient unit. Once those symptoms are managed, though, they're supposed to go back to their place of residence. That being said, sometimes people don't want their family member to die in the house. You know, sometimes, you know, as we had a cancer patient last summer, had 2 teenage daughters in the home. And so, you know, usually there are some symptoms you can manage at the end, be it breathing, pain, whatever, that people can, you know, you can work it out so that they can go in there and pass there. There's also another level called respite. Respite is a 5-day period. It's 5 nights, so kind of 6 days that, and it has to be offered if you're Medicare, Medicaid covered. So the person can go into the facility, stay for 5 days, and it's mainly just to give the family a break. You know, because some of these families have patients that have ALS, they have dementia, they have really long-term illnesses, and they just get exhausted. So it's really, even if the family's just going to stay at the house and sleep, that's what it's for.
Lisa?
Yes.
How often would they be able to use a respite type?
You know,
in a year's time period?
It depends on the facility. They say it changes. You know, they keep coming up with different regulations on that. It's really supposed to be, I don't think there is a set day. I know the place I worked before, they had gotten in this habit, some of the staff, of telling people every 30 days, which is not true. It's supposed to be maybe twice in a 6-month period.
But Medicare will cover it every 30 days. People just don't use it.
It depends on, they will. So anyway, but the main thing is too, do you want your loved one to move them back and forth every 30 days too, for a week at a time? You know, that's not good for them. So the Medicare benefit and the Medicaid benefit is 100% for hospice. Now, hospice is set up very different than home care. You know, we bill out most things, most everything. Hospice, if they take care of a patient, they cover all the medications related to the terminal illness, and that's dependent upon what type of illness you have. But pretty much all of them are covered for pain medicines, all those types of things. But, you know, if you have a patient that's cardiac, then their cardiac meds are going to be covered. So it really does help the family financially because that's covered. Their DME is covered. You know, different hospices can cover what they want to cover. Hospice Medicare benefit pays like around $120 a day, I believe it is now, maybe $130 for per day that the person is on hospice. So out of that, they've got to pay for the skilled nursing, social worker, chaplain, not volunteers, the nurses, and home health aides, and the medications, the DME. So families do get more than they do when they're on home care. Of course, you don't ever want to push somebody into hospice because of that, but just keep that in mind too. Let's see, come on over this. You know, one of the myths about hospice, like I said, is that people think, oh, I'm going to hospice to die. They put Aunt Sue in hospice and she died a week later. Well, unfortunately, it's because Aunt Sue was dying a week later. There was a study done in 6 categories of Medicare patients. Out of 4,493 patients, the ones that went on hospice as opposed to the ones that didn't with the same disease process, the people on hospice lived longer, a mean average of 29 days. And it was interesting because of our CHF protocol, CHF was the one that had the longest, and it had a mean difference of 321 days for non-hospice and 402 days for hospice patients. You know, a lot of that is because, you know, with home care, it's short term, it's just to get over this hump, you know, to get through whatever the skill is, but hospice is not like that. You know, it's kind of sad because with home care, you know, people are supposed to be homebound. Well, then you get them in hospice, it's like, oh no, go out to eat, go shopping, go do all these things. And so they, I lost my train of thought. So anyway, it does increase lifespan. People think
Quality of life.
Yeah, quality, right? Exactly. Well, it makes you live longer, and they have found that it does increase the quality of life also. Exactly. See, I've given y'all some handouts. One of the handouts is from the National Hospice and Palliative Care Organization. It has some really good information in it, and it talks about the different levels of care that we just went over. It also talks about, you know, one reason that I think people do better, or I shouldn't say better, that they have a longer lifespan is that in hospice you have a medical director that's over the hospice team. And that hospice team, like I said, involves nursing. You have to have a medical director, nursing, home health aides if they want them, social worker, and chaplain, and volunteers. And a lot of them have dietitian now also. And every single week you have to have an IDT meeting. You have to, as a whole team, every single skill has to be represented, and the medical director has to be there. And then every patient has to be discussed at least every other week unless there's an issue going on. Then, of course, you can bring them up. Because of that, you know, there's just more interaction between the doctors and the medical directors. You know, get to know the patients pretty well because you're covering all that. And you know, you're seeing the patients more often. I had a patient that was 101 over at the tower, and you know, she didn't have any skill to be on home care, but she was 101, she had heart problems. So I went to see her one day and she goes, I just don't feel good. Well, her heart rate was down to 44, and I called the doctor, got her medications changed. She came off of hospice at 102 because she just kept doing fine. And I think that's part of it. There's just lots of follow-up, and it's continued follow-up. And I didn't mention, hospice is the certificate periods are 90 days, and then unlimited 60 days. So, you know, it's a longer period.
Yeah, it took her a minute, and she had to call her supervisor.
All right. So on the one paper that I gave you all, there's lots of different types of these sheets out, and it's just a real little cheat sheet for determining if somebody's eligible for hospice. You know, last summer when we were talking with one family about hospice, I kept saying if she's appropriate, because I didn't think she was renal failure. And if you look on here, to be renal failure, your creatinine has to be 8. 6 if you are renal failure, hospice appropriate, the creatinine is 8, which is high. But if you're diabetic, it's 6. I know, I showed our doctor one day, I was like, yeah, but the creatinine's on 1.5, and he's like, this, or whatever it was, he's like, well, it's getting up there. I'm like, yeah, but it doesn't meet criteria. So anyway, I just thought if you'd like, you can keep these in your, you know, put them in a little folder, keep them in your books, whatever. If you have a patient that you think might be appropriate, before you even breach it with them or the doctors, you know, you can look at this. It also has the palliative performance scale on it. And I gave you another sheet that has the Karnofsky and the PPS scores on it. So, you know, a lot of times doctors, you know, unfortunately, fortunately, doctors are all about cure. And sometimes it's not what's best for the person. And so if you can call the doctor and say, this is what I'm seeing. You know, their Karnofsky score is 30. You know, according to this criteria, this is what's going on. They meet hospice eligibility. And, you know, a doctor does have to certify that they meet that criteria. I will tell you, sometimes if situations, you know, every hospice is different. As you all know, since we are affiliated with a hospice, that hospice, a lot of times families think hospice is this one big umbrella organization like the government hospice. And, you know, it's not that way. You can, if the medical director will look over the information, and they can also decide if the person's hospice appropriate. And anyone can make a hospice referral. If it's something that the family's interested in, the family can call the hospice and say, I think Mama needs hospice, can you come out and assess her? And they can do that. One thing that was interesting, I found that CPR statistics, you know, even now when you talk to people in their 80s with about CPR, they think, well, they can come do a little bit, and, you know, unfortunately don't realize it's not just a little bit. This study found out of this 100 patients and like 50 of their family members, 55 to 56% of them got their teaching about CPR from TV. You know, and that's seeing it on ER and seeing it on all these hospital shows where everybody almost survives CPR. One of the statistics showed that from the American Heart Association that patients that have MIs at home have a less than 8% survival rate. So, and CPR is, you know, the older you get, the lower and lower and lower your survival rate goes. And if you have a terminal illness on top of it, it's almost nil. Let's see. This one study, they performed CPR 400 times, 329 seriously ill people, 22 survived till discharge out of the people that were revived. Another one showed that this was based on patients 69 years old and older, that 112 of the 503 patients that received CPR, they did respond initially. Only 19 survived to discharge though, and of those 19, half of them had significant brain damage. So, you know, you don't ever want to take people's hope away. You don't ever want to do that, but you also, it's our job to educate people. Educate, and empower them so that they make good decisions. You know, unfortunately, for whatever reason, you know, doctors don't want to discuss sometimes a lot of these things. You know, they're very busy. You know how offices are. They've got 6 patients in rooms, and so, you know, it's important for us to educate people. Let's see. And I'm just going to tell you a few things about care of hospice patients, and then we'll be all finished. You know, they do have different needs. You know, one of the myths is that, well, they send them to hospice and they starve them to death. They won't give them anything to eat. And kind of like your ketchup bottle analogy, I always tell families that are having a hard time understanding, I said, you know, it's kind of like having a car sitting here idling. They're kind of on idle right now. I said, yes, they're going to use up some of that gas, but you can't just put the gas pump in there and leave it running, because it will spill over. And you know, that's the same thing that happens with hospice patients. If you try to, or anybody at end of life, I know all of us have taken care of patients that are so bloated. You know, they've just got generalized edema, weeping, and it's because they're so fluid overloaded. And people used to, you know, always say, well, how do you, does that not break your heart to do hospice? But I will tell you, what breaks my heart worse is to see people come straight from the hospital and lay there and drown because they have so much fluid in their lungs. And I worked in the ICU, and I worked on med-surg, and I do think that there are times it's wonderful and it's definitely needed, but you know, I think we need to help people be educated so that they can choose to make decisions based on education and not TV, you know, decisions. So, as people decline, their bodies quit wanting food. And they even will quit swallowing. You know, your mouth is all part of your GI tract, so they'll quit swallowing the food even. You know, I told families, you know, for thousands and thousands of years, that's the way we died. We didn't put IV tubes in people, or tube feeding and IVs and give them stuff like that, and they died okay. You know, so it's just normal. You know, people at a baby need something different than a 16-year-old needs, something different than a 50-year-old needs, and something different than death. Yes, ma'am.
When a patient is in that dehydration mode where they don't need or want food, fluids anymore, a lot of families want IV fluids. And the 3 patients that I started IVs on that were on hospice died within 24 hours because it's an overload on the heart.
Right.
It hastens them.
It does, and it makes them die. I mean, I've taken care of patients where you could hear them breathing from the nursing station, you cannot get it out. That is the most gut-wrenching, heartbreaking thing, is to watch people lay there and basically drown to death. I mean, that's really what they're doing.
Studies show, though, that the death rattle, you're not suffering. They are not suffering.
Death rattle is different than having fluid in your lungs. Death rattle is when you have that little bit of basically snot, sputum in the back of your throat. And you know, we've all been sick, and that's all that is. It's just stuff. They don't have the muscle strength to cough it up. They don't have the muscle strength to swallow it down. So that it sticks right there in front of the flap and just rattles every time they breathe. Studies have shown that patients that are a little dehydrated die more peacefully because their lungs are drier. Like I said, another myth is that they put everybody on morphine and they die. Well, I'm here to tell you, I've taken care of people that have been on 1,000 milligrams, literally, a day of IV morphine that were walking and talking. You know, we come from a very different place, and when I first came from the med-surg floor to hospice, like I said, we used to deliver our own medicines, and they gave me a 1,000 milligram bag of morphine to take to a family. You know, I come from where you gave a milligram, you went and watched them every 5, you know, make sure they're still breathing. And she said, yeah, just give it to them. You just want me to give this to them? They really do build up a tolerance. And it really does help people breathe so much easier. It relaxes the lining of the lungs. It helps slow their respiratory rate when they're breathing 30 sometimes a minute. That's a good thing. So anyway, a couple other things. You know, we don't starve them. If they want donuts and they're diabetic, they can have donuts. You know, they don't need to eat 13 donuts, but they can eat a donut or 2. You know, at that point, it's all about comfort. It's all about quality of life and living the best you can live it. You know, people do have terminal agitation sometimes, where they start feeling like they're just, you know, everything just starts misfiring in there. So that is one reason that they are sedated sometimes. And it's a very uncomfortable way for somebody to live, having that terminal agitation and just, you know, be trying to crawl out of the bed and everything. They will start running hot, which is normal. You know, people worry about temperature, check their temperature, we need to give them something. but it's just the dehydration, it's the changes in the body and everything that's normal. All right. Do y'all have any questions for me?
I think one of the, since we're not usually involved in the last stages of all that, 'cause we're at the end where they need to move into hospice
Right.
or start thinking about it or present it to the family. I find that is like the most uncomfortable conversation to have on the planet.
It is, and it can be, and I still do it. When I go do admissions, I talk to people about, if I see that they're really hospice appropriate, I tell them, I hope for you, if your goal is to get well, that is what happens. But if it doesn't, if things don't go that way, there are other options, and I would just like to tell you about them. And just explain to them some about hospice. Also, I think that advanced directive in the book, I explain to everybody, even if, I tell their family members, even if you're 40, do an advanced directive. And as things change, I've had several people say, well, I have one, but it was years ago we did it. And I said, well, then you might want to readdress it because, you're not the same as you were then. And, things are changing. And so I think that you just have to, we need to think of end of life as a part of life and not, we're just, the hospice is about death. It's about death. It's really, truly living each day the very best you can live it. And then when that time comes, helping people be as comfortable and peaceful and die with dignity and respect.
So how is it, those evaluation scales that you mentioned, are they a little bit subjective? And would that be why some hospices accept the patient after some other hospice did not?
Right. Well, I will tell you that every hospice can choose to accept who they want to. Just like in every areas of life, there are scrupulous hospices and there are unscrupulous hospices. When I was the unit manager where I came from, I stuck with the guidelines. I was not going to lose my license, by committing Medicare fraud, and I wasn't going to get our company in trouble by doing that. And we had patients that we had to discharge off hospice, and other hospices will pick them up. They will, and there are hospices that are being fined. I think one in Alabama a couple years ago got the biggest fine ever, and it was multiple millions of dollars. Because of Medicare fraud. And it's happening more and more that they're, as Medicare's tightening down and looking at things more, they are finding that, they're looking at those different things. So that's why some hospices will accept people and some won't. Sometimes, there are hospices that won't accept somebody because maybe they didn't want to have to deal with something the person's going through. If you know that's that is something that people, like palliative radiation, most every hospice will accept a patient on palliative radiation. So if you have a hospice that, says they won't accept them on palliative radiation and you really feel like that person needs hospice, there are hospices that will accept them, and it is within their right to, they are the ones that's paying for that palliative care, just so you know. So if you do talk to a hospice, you see that they're meeting the criteria, the family really wants it, but the hospice you contact does not want to admit them at the time, I feel like it's our responsibility as an advocate for the patient to get them the care they need. So, okay.